Hello, everyone. I'm Dr. Patience Atumanya. I'll be co-hosting this with Dr. Agaba Peter. He's an anesthesiologist and lecturer at Makerere University. We're going to be looking at anesthesia and critical care in the COVID pandemic, and we shall be sharing ICU experiences from the different areas. We have 3 speakers. The first one will be Dr. Emmanuel Ayebale. He's the acting instructor and fellow in anesthesiology and global health at Harborview Medical Center, University of Washington, USA. The next will be Dr. Peter Kairuki Ngugi. He's an anesthesiologist at the Department of Anesthesia and Critical Care, Kenyatta University Teaching Referral and Research Hospital. That's in Nairobi, Kenya. And finally, we'll listen from Major General Dr. Shina Ongibinyi. He's the president of the Intensive Care Society of Nigeria, and he's also one of the critical care pillars in the COVID-19 response in Lagos State, Nigeria. We shall be taking questions at the end of the entire presentation. You can send them through the chat room. Mary will be reading out the questions, and then we listen from our panelists. Dr. Ayebale, you could share your screen and start off with the session.
All right, thank you very much. I hope I can be heard clearly.
Yes, we can hear you.
Great, fantastic. Good evening, everyone. My name is Dr. Emmanuel Ayebale. I still like to believe that I am Ugandan, although some of my colleagues try to kick me away. I still like to think that I work with Makerere University, even though I resigned. Right now, I am an acting instructor at the University of Washington in the US. And I just want to share the US experience with COVID-19 and wrap up with lessons for Uganda. I will talk about what has happened here in the US. Initially, the plan was to speak about Seattle, where I am, and incidentally, where the outbreak started. But I felt it more appropriate to speak about the US as a country. Then I will quickly talk about Africa. I won't waste too much time on that. And then I will share my thoughts on what I feel should be the way forward for Uganda. I don't have any conflicts of interest to declare. The US has been the hardest hit in this pandemic, which is pretty surprising because we had ample timing to plan and prepare. About in February is when the very first case was reported, about 4 miles from where I stay here in Seattle in Washington. Since then, we've had over 2.7 million cases to date, with over 128,000 deaths. We're not even over the first wave of this pandemic, and we're already beginning to see a resurgence in cases as states open up. Some states didn't even close completely. We are relaxing social distancing measures. For those of you who follow the news, there were pretty big riots across the US and across the world in the last few weeks. And there's been mixed messages from the highest office as to how we should go about looking after ourselves in public. 3 days ago, the US recorded its highest daily increase in coronavirus cases at over 54,000. And that is only set to go higher and higher, which is pretty worrying. The first papers describing ICU patients in COVID-19 actually came from the University of Washington. But I have chosen not to describe papers from Seattle. I want to talk about New York, because New York was the epicenter and technically still is the highest risk area, although that is rapidly changing. This is the biggest study that we have so far, describing 5,700 patients that were admitted to this hospital, to a couple of hospitals in New York. I chose this study because the findings of this study agree with a lot of big studies that have come out of China, out of Europe, and now coming out of the US. And I think this will speak very nicely to what the demographics were. Basically, if you are older, anywhere above in the 60-year-old range and above, if you are male, and if you had hypertension, if you're obese, and if you had type 2 diabetes, you had a very high chance of being admitted into hospital and ending up in ICU. Even though at the beginning of the pandemic, it wasn't clear how smokers were affected, it seems a lot of the patients that came into this study weren't actually smokers, but they had at least one comorbidity. And this was pretty important because of all the patients that were admitted to hospital, and mind you, by the time this paper was published, half of the patients were still inpatients. 14.2% were admitted to ICU, 12% of patients got ventilated, 3% required renal replacement, which is pretty much in agreement with a lot of the studies that have come out of different settings. But what this study did, and why I chose this study, was this was one of the studies that led people to believe that mechanical ventilation was killing patients. There was pretty high mortality reported for people who were especially older than 65 years old, about 97% of them, and this was halfway through the study, 97% of them were dying. And there was a general notion in the media at the time that this disease is not a lung disease, so mechanical ventilators are killing patients. That is not the appropriate treatment. Of course, now we understand that these people were older, already had lots of comorbidities. They were already in a high-risk group, and COVID-19 with all its sequelae of complications was just too much for them to take. These findings were again confirmed by another pretty big study that came out of New York. This one had about 1,100 patients. Once again, comorbidities were pretty similar. But what I wanted to highlight from this was patients who needed advanced therapies in ICU, particularly ECMO, which is about 6 out of 203 patients, about 3%. Not that much, and lots of studies from different high-income settings are showing that ECMO is used in different places for different reasons, but not as much as we would have expected. This study also used hydroxychloroquine, remdesivir, and I'll talk about those later on. But what I found pretty important from this study was the risk of death. And there's been a lot that has come out on mortality from COVID-19. Basically, the older you are, again, if you happen to be a man, if you had coexisting disease, particularly high blood pressure, lung disease, kidney disease, diabetes, if you're obese, and more importantly, if you had raised inflammatory markers, especially interleukin-6 and D dimers, you had a higher mortality rate. And this was around the time that a lot of studies were beginning to report coagulopathy in these patients. There was evidence of small vessel disease, particularly endolithitis, if that's what I don't know if I'm saying that correctly. But basically, there was widespread capillary damage. There was activation of platelets. There was altered blood flow in these patients. Virtuous triad basically came together beautifully to cause lots of microthrombi basically throughout the vasculature. And there were even reports of stroke from large vessel thrombus. So all these patients started getting anticoagulated. When you look at deaths, looking at projections from the Institute of Health Metrics, where I am, if all goes terribly, meaning as if all goes the way it is going right now, we can expect to see about 175,000 deaths in the next 3 months total. If we can wear masks in public and social distance, which looking at the way things are going in this country, I think that's going to be pretty impossible. We can expect about 150,000 deaths. This is sad because when we look at who is dying, even though African Americans have been have made up about 20% of the population of patients that get to ICU, their death rate is about 2.3 times higher than that of their white and Hispanic counterparts. This has also been shown in the UK. There's a pretty big study that has come out where they're looking at over 17 million NHS documents. And it's showing that if you're Black and if you're Asian, you had a higher chance of dying. And it wasn't anything to do per se with your comorbidities only. There are other factors that are associated with deaths in this population that I will not go into detail at this point in time. At the height of the pandemic in April, we were seeing 2,200 people dying every day, at least. To put that into context, that is pretty massive. If you work in ICU, most of us work in probably a 6 or 5 bedded ICU, maybe 10, 11, at most 25 bedded ICUs. If you have 10 people dying in a 25 bedded ICU in one day, that takes a huge toll on everyone. At the height of the pandemic in New York City, these were the numbers that were being witnessed. And around the time, if you remember in the media, there were pictures of mass graves being dug in New York City, scenes that were pretty harrowing. Where we're at right now, which happens to be Independence Day here, we have about 646 people dying every day. If we can wear masks and social distance and do everything correctly, by October, we'll actually be seeing about 71 people dying per day, which would be fantastic. Well, not fantastic, but not as bad as it is now. If the trend continues the way it is right now, we can expect 550 people dying every day here in the US. For a country that has about roughly 350 million people, those might not seem big numbers, but on the ground, it's pretty big, especially when you think about hospital resource use. Again, I keep throwing these graphs out just to make things a bit more understandable. At the height of the pandemic, we were occupying over 18,000 ICU beds. These ICU beds were not all existent before the pandemic. Many of them had to be made ad hoc, more or less to fill in a gap at the time. And this will be important when I talk about surge capacity planning later on. Where we are at today in the US, there's about 6,000 ICU beds that are occupied, which is a pretty big decline from 18,000. But when you look at what's happening, and this was updated yesterday, this is from the CDC website, the states in the south, southwest, and the southeast basically have over 70% of their ICU beds occupied right now. Where I am in Washington State, which is up in the northwest, we're at about between 50 and 60% of our ICU beds occupied. If the numbers continue climbing the way they are right now with record daily increases in cases, we can expect to see in the next 2-3 months an overwhelming of the ICU capacity once again in some of these states, especially if they haven't planned enough. And by October, worst case scenario, we will be looking at needing 12,000 ICU beds, which won't be 18,000 as it was before. But once again, these are just projections, these are estimates, and these estimates are based on current data. These estimates could change pretty quickly. Looking at ventilators, I found this pretty interesting that at the start of the pandemic, there were about 55 ventilators that were needed, 55 extra ventilators that were needed, which, if I remember, one of our esteemed members that is moderating one of our panels today published a paper showing this is roughly Uganda's ventilator capacity before COVID-19. Hopefully things have changed now. But it's pretty interesting that within a month, actually within less than a month, within 3 weeks, the need moved from 55 to 16,800 ventilators that were occupied. And at that time, there was need for even more ventilators. It's a pretty big jump in a space of 3 weeks, less than a month. And this is just to show you when we talk about overwhelming hospital systems, this being the US, the most resource-rich country, even this jump was too much for the US to handle. Where we are right now, about 5,500 ventilators are being occupied. Again, this is not as much as what we're seeing in April. But if we are to project, worst case scenario, we're going to hit 11,000 ventilators plus. We will not exceed such capacity if things continue along the current trend, only because ventilators have already been made available. However, as I said, these numbers could change pretty rapidly, and we could end up, it's possible we might even end up in a worse case scenario than we were back in April. That said and done, I just want to quickly talk about what has been happening in terms of research. drugs. I won't talk about vaccines, but I want to talk about drugs, and especially drugs that have been showing mortality benefit in ventilated patients. Remdesivir has been pretty big. There have been conflicting results from different trials, but overall, it seems this might be the one drug that seems to be showing consistent mortality benefit in ventilated patients. So much so that as of yesterday, the US had bought up more or less all the remdesivir in the world. There's only little left elsewhere for people to acquire. But that shouldn't make you lose hope. India has started making remdesivir, and it's actually going to be cheaper than the remdesivir being produced in the US. So you might want to look out for that remdesivir. It will be more than half, less than half the cost of what Gilead Pharmacies is selling it at here. In the past few weeks, dexamethasone has once again arisen. For us in critical care, we'll know that steroids have come and gone over the years. Looks like they're back, and dexamethasone seems to be back in a big way, with a trial out of the UK showing a pretty significant mortality benefit in patients that need oxygen, but especially patients that are mechanically ventilated. 6 milligrams once a day for about a week seems to do the trick. Hydroxychloroquine has gone back and forth. This is probably the most controversial drug to date in COVID-19. If you ask me what's going on with hydroxychloroquine, truth be told, I have no idea. A few weeks ago, it seemed to be the magic drug, and then it more or less was dropped off the scene. And now it's getting picked up again with big trials continuing to use hydroxychloroquine. With conflicting findings, I think we can agree right now that some of the big studies coming out are showing that there is no mortality benefit, and there may actually be harm caused by the use of hydroxychloroquine and azithromycin. That said, a lot of places are still using hydroxychloroquine for what it's worth. Convalescent plasma, which is basically plasma donated from people who have recovered from the disease, is becoming a big thing, and patients are donating their plasma. There are varying results. There are some pretty good results out of China showing that there is a mortality benefit, but it's a bit too early to tell. Tocilizumab is becoming pretty big, especially in the US. This is an interleukin-6 antagonist. There are pretty big tocilizumab trials that are running right now. Early results show that it might be positive. We shall see. I just need to stress that none of these drugs have been licensed by the Food and Drug Administration, the FDA authority for treating COVID-19 patients. But in a pandemic like this, there is almost no time to wait for FDA approval. If there are early signs of benefit, these drugs get used pretty quickly. For example, the dexamethasone trial hasn't even been peer-reviewed yet, but it's already changing policy around the world. And then there's a couple of other antivirals that are being tried with limited success. And there are other inflammatory mediators like colchicine and ivermectin, which are showing results in vitro, but we don't know what's going to happen in vivo. I want to very quickly touch on Africa, only because it seems for now Africa has been spared the brunt of this pandemic. Whether it's because we are beginning to rise up along the curve to head to our peak, we do not know. But we've seen about 174,000 cases and 6,500 deaths, most of these in the south and the north. It looks like East Africa and Central Africa are being spared for now. Whether this is actually true reporting of cases or whether we are having partial reporting, we don't know. But from what we are seeing, the north and the south are bearing the brunt of this pandemic in Africa. The WHO released a study basically predicting what would happen if we have widespread community transmission in Africa. And from what they're telling us, we could be looking at about 150,000 deaths on the continent by the end of this year and 89,000 ICU admissions. Where this will be spread out, probably still the north and the south, but with numbers like this, it will be very hard for the east and the central to miss. So what does this mean for Uganda? I think Uganda, of most African countries, is pretty unique so far in this pandemic. We have just under 1,000 cases and no deaths. This is confusing a couple of people. I think this is a very good problem to have. We reported our largest daily increase in cases on Martyrs Day, which was June 3rd, and that was 128 cases. Compared to 54,000 cases here in the US, I mean, you can see that there's a very big discrepancy. But from projections right now, if we continue on this current trend, IHME, the Institute for Health Metrics, is estimating that we might see, you know, by October 1st, about 14 deaths, which in the grand scheme of things is nothing to write home about. But remember, these are projections that are based on current trends. So what does this mean? Everything seems to be going good for Uganda right now. We seem to have had a very strict lockdown that's being lifted. Most of the cases that are reported are not even Ugandan nationals. They were truck drivers from our neighboring countries. So Uganda per se seems to have controlled the pandemic pretty good. However, I would want to take this with a bit of caution. And the way I see it, this is more time for us to plan. And I think one of the things to plan for is to collect data. Whatever is going to happen over the next few months, we need to make sure that we collect that data very seriously and use that data to make projections. All these projections are based on mathematical models, and those models need data. So a model is only as good as the data you feed it. So the better data we have to feed into these models, the better projections we will get. But I still urge us in Uganda to plan for the worst. Planning for the worst doesn't mean the worst will happen, but at least it will do one of two things. One, it will help us get our critical care capacity up, and two, if the worst does happen, we will be prepared. There are ways to do this. There's lots of surge capacity calculators online. Different organizations have all sorts of calculators that you can feed data in, and you can actually get what would happen in different scenarios. I want to emphasize that you should keep a very close eye on PPE. PPE runs out very fast. We've seen that here in the US. At the start of this pandemic, we ran out of PPE very quickly. Masks, head caps, disposable gowns, gloves, N95 masks were probably the worst hit. So you need to keep in mind that PPE runs very fast. You need to make sure that you keep a very close eye on how people are using PPE. You can even calculate how fast your PPE is going to run out, and you can plan better for how to conserve PPE. If we do have a very big surge, you can anticipate that providers will burn out. You need to prepare for that. There is lots of guidance online for how to manage critically ill patients. As we get more data from COVID, it's good to follow all that guidance. Don't worry about all these fancy drugs. Use what you have. If it is used right, you will save lives. And it's always good to work with our neighbors to coordinate regional efforts. And whatever is going to happen at the end of the day, there's going to be good data. That is data owned by Africans. That data should be published by Africans. That data will be used to inform policy, but it will also help us understand this pandemic better. Thank you very much, and I will take questions whenever the moderator sees fit. Thank you.
Thank you, Dr. Emma. We shall hold the questions for all the attendees. You can keep forwarding the questions into the chat room. We shall respond to them at the end. We shall hear from Dr. Peter. If you don't mind, you could share your screen, and then we'll start that session. Dr. Peter, can you hear me? All right.
So good evening, my name is Dr. Google. I work in a referral hospital in the city of Nairobi. So among the few centers which are currently handling the COVID-19 cases here in Kenya. So I'm going to talk a brief presentation about our experience as a hospital and as a department when it comes to the management of these COVID-19 patients. So we have an ICU, which is a 24-bed ICU. And so we have been involved in the management of those patients who come with severe COVID-19 disease. So, as an overview of the epidemiology in Kenya, the first case was reported in the 12th of March this year. Only around one case during that day, and then the month of March and April, there was a very low reporting of cases every day. But over the last 2 months, that is around May and June, the cases have been increasing gradually every day. As at the end of this month, we have recorded a total of 7,188 confirmed cases, and out of these patients, 2,148 have recovered, and unfortunately, we have about 154 patients. This is a case fatality of around 2.14%. Out of the 7,000, our hospital has admitted around 993. The reason we have admitted this number is because initially we used to admit all the patients who turned positive, but then after some time, when they now be so many, all of them could not admit. The government has come up with protocols for home-based care. So at the moment, only the patients who have symptoms and actually moderate to severe symptoms are the ones who get that. So when it comes to our age distribution, we have had 2 weeks, that is the lowest age, and the highest age is around 85 years. But the majority of the patients come in the age group of around 59 years. We suspect the reason for this age group more affected is because this forms the major chunk of the population, especially within the city, who are working, and so we are always moving up and about, and so they are able to interact with patients who already have contracted COVID cases. Because when you look at the older age group, especially the 60+ years, most of these populations are not in the cities, they are back in the rural areas, and our country, we had instituted the cessation of movement from Nairobi, the cities of Nairobi, Mombasa. So this maybe could be the reason why we have prevented the spread of cases to those individuals who usually reside in the areas. Again, the younger age group, possibly because most of them they are school-going children, and now the schools are closed, so most of them are at home, and the parents maybe can be able to ask them to remain at home. So out of these 990 patients, the patients who have been admitted in the critical care units are 30, which is roughly about 3% of all the hospital admissions. Of these, 4 are males and females are 6. So we can see that the males are more affected by COVID-19 more than the females. And this actually even compares even with the cases which are reported nationally. They usually have a very high proportion of males getting infected than the females. So you have a male-female ratio of 4:1. So when it comes to ICU, the age distribution, again, the same age group of around 41 to around 70 years. The youngest patient we have had in our ICU is 31 years old, and the oldest we have admitted is an 85-year-old patient. But the biggest group is the one which is around 61 to 70 years. I mean, 61 to 60 and also 61 to 70. This forms the major proportion of this patient. Maybe the reason which can explain is this: these are the patients who usually have comorbidities like hypertension, diabetes, heart disease, asthma, COPD, because these are the patients again who are usually presenting with this severe COVID-19. So, of all the patients we have admitted, it's only one patient who came with comorbidity. All the other patients we have admitted, either one or some even had around 3 comorbidities. We found that diabetes mellitus is the commonest one, followed by hypertension and end-stage renal disease. End-stage renal disease usually occurs in either a patient who has either diabetes or hypertension. Then the other one is HIV/AIDS. Then we have a heart disease, COPD. We also have patients with anemia. We have also admitted one patient who came with severe PET, pregnancy, and she was a term. So she was admitted and then treated and then delivered home with a baby. We also have had admitted one patient who came from, referred from another hospital where he had been admitted, had done a total hip replacement, and then the patient presented symptoms of respiratory symptoms. Then when the symptoms were sent, that is when he was moved to us. We tested for COVID and he was positive, and unfortunately, he's one of our patients who never made it. So you also have admitted one patient with cancer. He had a metastatic CNS. So when we look at the indications for the patients to be admitted in ICU, we find that respiratory failure was present in all the patients. Basically, respiratory failure was the reason why all these patients were admitted to the ICU. But there are some who came now with respiratory failure with also another condition which can make an indication for ICU, but it came with respiratory failure. So the other complications were uncontrolled blood glucose, especially in patients who are diabetic. Actually, we have admitted a patient who actually 2 patients who presented diabetic ketoacidosis, and also we have also admitted several patients who they were not diagnosed with having diabetes before, but they just got diagnosed with diabetes and then started developing the symptoms of COVID. We have had around 3 patients who are being diagnosed diabetic and also presenting severe disease. Then the other patients were renal replacement therapy. So the reason for this admission was because we decided to keep our dialysis unit open for patients who don't have COVID, and then we piped our ICU with we made piping for dialysis in our ICU. Even the patients who get admitted in now the isolation unit and still with dialysis, we get admitted to the ICU, dialysis and discharge. But the one whom we admitted had either respiratory failure or maybe uncontrolled diabetes. The other case was also uncontrolled hypertension and also severe PET, the patient I talked about earlier. So when we came to our treatment, basically we have been relying on information which we done from other people who are doing in other for example, the UK, Italy, the US, and also locally we also compare notes with other colleagues in different hospitals, especially the private hospitals, who have been also managing these COVID-19 patients. And so currently what we are giving our patients, all of them when we admit them, we put them like we're giving a dose of 4 milligrams three times a day. We're also putting them on vitamin C, either tablets. Those we only want to give the injectable, we also give Abrinex 1 and 2. Of course, we have to give the ulcer prophylaxis. Then analgesics, because most of these patients present with either generalized body aches, sometimes very severe headaches, abdominal pains, and also they present with very high fever. So we also give them analgesics and antibiotics. Currently, we are using paracetamol to avoid the NSAIDs. Then for patient whom we are intubating and mechanically ventilating, again you have to give sedatives. And sometimes it becomes very hard to sedate these patients. We find ourselves using, for example, some even requiring 4 drugs. So in some cases, in the acute phase, we usually combine the sedative with the muscle relaxants. Then we also give them an auxiliary. This one we based on the studies which were done in Italy, which suggested that most of these patients are having microthrombi affecting the pulmonary vasculature. So because of this, now we decided to, instead of giving the subcutaneous prophylactic dose, we just give the full therapeutic dose for an auxiliary. So we are giving 1 milligram per kilogram twice every day. Then antibiotics. For all of the patients, we are giving azithromycin as a standard. And then, depending on the septic screen, I think there is these septic markers that is the CRP, the procalcitonin, we also do blood cultures and tracheal aspects for culture and sensitivity. Then we grade our management of the antibiotic management depending on the sensitivities. So remember, our patients come with comorbidities, so we also have to take care of the comorbidities. So what we usually do, we just continue the long-term therapy depending on the clinical state. For example, patients who are taking antihypertensives, when they get admitted, and then for those who are unfortunate to get intubated and mechanically ventilated, in fact, that after you start the sedation, most of the times the blood pressure usually come down and have the need to continue the antihypertensives. But for those who are not intubated, we just continue their oral medications if they can take them orally. If they can't take them orally, then we pass an tube, then we give them by tube. For the patients who are diabetics, we usually prefer using insulin infusion and then keep monitoring the blood sugars. Because also with the use of dexamethasone, we are finding it very hard to control the sugars. That is why we usually prefer the insulin. We have admitted patients with severe anemia, so we have also transfused them. Those patients who come with either they are known to have hypertensive disease or they develop acute kidney injury during the course of the disease, we usually do the renal replacement therapy, that is dialysis. And also nebulization, especially for those patients who have a history of either asthma or COPD. So we come to the respiratory support. Majority of our patients have been mechanically ventilated after doing a tracheal intubation. That is 80% of them. We have managed to successfully treat 4 patients without having to intubate them or use the NIV. Those are patients who just come, then we relax them, then we usually put the NRM mask, because one of the reasons maybe they usually get admitted is people in the ward usually don't fit non-breather mask. So we find that most of the time there are those valves which are open, and the mask is just functioning when they are not a mask. So when they come, for us, we know that you have to cover those valves, and then you see that the saturation usually go up with them, even without having the liquid. So we don't intubate. So that's for 2 patients. I mean, for 4 patients. We have also done non-invasive ventilation. We have done non-invasive ventilation on around 6 patients, and 2 of them have been successfully ventilated without anything else. But unfortunately, 4 patients, they became so agitated and they couldn't tolerate the face masks. So they had to be intubated and mechanically ventilated. So when it comes to ventilation, there are those guidelines for in the initial stages. I mean, in the initial phase of the pandemic, which was combating the use of the ARDS protocols for ventilation. So we have not been doing that because we discovered that most of the patients, they usually don't have a problem with the carbon dioxide, and most of the time they don't have a problem with the lung compliance. So we have just been doing a individualized kind of mechanical ventilation. Now, when we admit a patient, we intubate, and then we just use the normal settings for mechanical ventilation, and then now we keep observing and see whether we need to increase either the threshold or the PEEP, depending on the clinical condition, and also the report of the blood gas analysis. So the other supportive management we have also been doing, pronation. There are some patients who have who usually improve their oxygenation when they do pronation, either self or passive. The self are the patients who are awake, either on an ventilation or the mask. You just encourage them to pronate themselves as much time as they can and tolerate. For the one we are doing passive ventilation, I mean mechanical ventilation, those are the ones now we passively prone. We usually prone them for around close to 16 hours, and then we keep them fine for the next 8 to 12 hours. Then for nutrition and fluid therapy, we usually encourage oral feeding. That is for those who are awake. For those who are either on an invasive ventilation, and those who are intubated, we do continuous gastric tubes. And usually we restrict the fluids to because we don't want patients getting fluid overload, and so we don't want the lungs to be wet. The other thing, chest physiotherapy is very, very important, especially the patients who have stayed for several days on mechanical ventilation. Initially, we find that the lungs are usual, but during the course of the treatment, they usually become very wet with some very deep secretions, and so chest physiotherapy has been a great help for majority of these patients. So during the course of this stay in the ICU, we have seen majority of them develop complications, and the commonest complications they have is acute kidney injury. This one has occurred in around, out of the 30 patients who have admitted, around 8 patients. This is patients who are admitted without the end-stage renal disease or without the renal failure, and then during the course of around the day 3 to day 5, then they start having features of kidney injury. When the urine output is low, then they will start the urea and creatinine in serum begin to rise, and by the time we are reaching the phase, they usually require dialysis. Then there are also patients going into severe ARDS, and despite all the maneuvers to improve oxygenation, they just don't improve in their oxygenation. You try proning, you try to optimize PEEP, you try to do negative ventilation, you try to paralyze the patients, but just the lungs are so bad damaged that all those measures don't the oxygenation, and so they just continue developing hypoxemia. Then the symptoms, features of global hypoxia, and eventually going to cardiac arrest. Then the other complication which has also been common is septic shock, usually occurring around the 8th day, and by the time they go into septic shock, usually the patients who have gone into severe RDS and also acute kidney injury. So it's usually a multi-organ failure syndrome. Then you also have coagulopathy. You have had patients. There's one patient who developed deep venous thrombosis of the upper limb. And also there was also another patient who was in the two extremes. He had deep venous thrombosis. And then he was having DIC. And so it was a very challenging patient to treat because you couldn't, if you're confident, you couldn't just treat. If you try to I was saying, if you try to anticoagulate him, he goes into bleeding. If you give thrombotics, then again, the kidney worsens. So it was a very challenging patient, and unfortunately, we don't. Then the other complication you have also seen is arrhythmias, usually develops also in the late stage. The commonest we have seen is the blood arrhythmias, and they're usually very even refractory to the inotropic agents. I mean the chronotropic agents. We try to give those patients dopamine or maybe and they still continue the blood arrhythmias just persist until they now be able to be arrested. We have seen one patient who came with COPD, developed spontaneous pneumothorax, possibly due to the increased intrapleural pressure. But this patient was very fortunate because despite having the spontaneous pneumothorax, we were able to maintain him on the non-breather mask, and actually he made it after around 10 days stay in the ICU. So patients have been staying in ICU. So far, the patient who has stayed with the maximum number of days is 15. There are those patients who came and died on day one. These are usually the patients who are admitted very sick and usually die at the initial attempt at the intubation. But our main ICU stay has been 8 days. So what we observed in the outcomes is that it usually depends on the severity of the respiratory systems when the patient is admitted in the ICU. Because we have discovered that patients who do not require advanced ventilation at the time of admission, they usually never had new complications. For example, if a patient who just came to the respiratory area, just fit the mask nicely and then start off the medical, they usually didn't go into those other complications of the ARDS, fatigue shock, acute kidney injury. And also, the patient who were ventilated by the NIV mask alone. So there was an associated outcomes than those now who were mechanically ventilated. So the severe respiratory syndrome usually correlated with severe complications. That is those complications of multi-organ failure syndrome, and these are the patients who most of the time died. So we have had several challenges when managing these patients in the ICU. One of the challenges is usually separating the suspect from the confirmed patients. Usually, our hospital usually also admits suspected COVID-19 patients, and so once in a while you might get a patient coming with severe pneumonia, presenting with the same signs and symptoms as the patients with severe COVID-19. And then now, because the COVID-19 test usually takes some time, and the patient needs intensive care, so you have to admit the patient. Now the problem is usually arises now: do you keep these patients among the others, or do you keep them in separate places. We usually try as much as we can to usually keep them, even if we're in the same ICU, we just keep them in a separate, for example, in the far corner, far away from the other patients. Or if we have an isolated, an isolated room, it's still within the ICU, we usually like to run the patient from the ICU. Then the other challenge is working in full PPE. The PPE is usually very uncomfortable. Usually it's very hot. You start sweating almost immediately, and then the goggles become foggy, and your vision is usually impaired. So very simple procedure, even for example, fixing an IV that can become a nightmare when you are in full PPE. The other issue is remote monitoring, because no one would really want to be staying in the PPE for a long time. Usually like monitoring our patients remotely. So what we have done, we are lucky that to have our ICU, it has a corridor between the, in between the wall that is the ICU and also the outside wall. And then on that wall we have glass windows. So we usually have we are able to move the patient from the outside of the contaminated area. And then from there now we also have the monitoring, which is located far from the contaminated area. So what we usually do when you come to review this patient, we usually do something we call a peer round. We just go to the windows, have a full examination of the patient, look at the ventilator, look at the infusion pumps, and then now have a plan of the medication which you are going to add in the syringes, and also the medications you are going to order from the pharmacy, and also those patients you are going to maybe get some laboratory samples, so that when you now make a plan before you go and enter the isolation area. It usually make your work easy because you have already made your decision. So when you enter there, you just to the actual procedures for that patient. Then the other one is patient movement within the hospital, because our hospital is not purely a COVID center. We also have non-COVID patients. So when you are moving one patient from one department to another, for example, from the isolation unit to the radiology unit, you have to do the plan. You don't want to contaminate the surfaces, so you have to organize with somebody from public health so that all the surfaces that the patient comes into contact with, they actually contaminated with. The other one is obtaining the clinical information from relatives. We usually don't allow visits for patients who are confirmed COVID-19. We don't allow relatives to come and visit them. First of all, is because we don't want to be in contact with the patient, and the other thing is because the patient, since the patient is coming from the community, these relatives may have had contact with this patient, and so then coming to us, we can also now spread the infection to the health workers, which means now the infection can be spread to the hospital. So getting information now from the relatives, usually I have to call them on phone and get information. Sometimes it is very hard because, especially when you are confirming the drugs the patient has been taking, and then the patient does not know the name, only maybe the shape of the color. Sometimes you ask them for calls. Some people don't have phones which can take pictures, so it's been a challenge. Then the other challenge is psychosocial issues with relatives. It usually comes because of the same issue. The patients, the relatives are allowed to visit their loved ones in hospital. So when the conditions of the patients change, you can only now inform them on the phone, and the eventuality that the patient dies, then it becomes very hard to break the bad news on the phone. And also, according to the public health regulations, actually they are not allowed to do the body of their loved ones. So it becomes usually a very emotive situation, both for the health worker and also the relative. But fortunately, these days now we have incorporated the services of the counselors and the psychologists, and so they are trying to help us in bridging this challenge. So that's the end of my presentation. Thank you for your attention.
Thank you, Dr. Peter. For those who joined us later, our theme was anesthesia and critical care in the COVID pandemic. We're sharing experiences. We listened from Dr. Emmanuel Ayevele, Ugandan born, but in the US. And the second speaker was Dr. Peter Kairuku, who's an anesthesiologist at Kenyatta University Teaching Hospital. That's in Nairobi, Kenya. Now, Mary will be taking us through the Q&A. Our panelists can respond as the questions come in. Dr. Mary.
Hi, everyone. I will read from the Q&A as well as the chat. And I think the first question in the chat was to Dr. Ayevele. Talking of collecting data which informs mathematical projections, what amount of truth can we put to our Ugandan statistics, given that we have had no death yet we've had a few number of elderly affected as well?
Yes.
Yeah.
Should I, more questions or should I respond to that?
Maybe you should respond to that one.
Yeah, that's a very interesting question because we've been having these discussions amongst colleagues, not just here, but I've been asking a few people back home what's going on. I still say that it's a very good problem to have. We have almost 1,000 cases and no deaths. That is highly unusual. Actually, I don't know if there's any country that has reported up to 1,000 cases and has not seen any death. Either we are missing these deaths, somehow people are dying and we are not picking it up, or they really are not dying, or there's something in Ugandans that is protective from dying from COVID-19. We don't know what it is. We may find it out one day, or we have maybe it's the BCG vaccine, maybe we have a different strain of virus. I don't know what it is, but I still think that it is good that for now we are not having any deaths. So when I talk about mathematical models, obviously we as clinicians know very little about mathematical models, but public health professionals are pretty good at this. And there are actually a lot of people in Uganda who are modeling different scenarios of COVID outbreak depending on caseload and deaths. So when I say feed this data into models, basically I'm trying to say partner with these people, these public health people, who are trying to predict what is going to happen, what will be the impact on our health system, the impact on our economy. The number of ICU beds, ventilators, patients admitted, deaths is very important data for any mathematical model in COVID-19. A lot of models that are predicting mortality and costs use ICU data. So if you have any patients that are coming into ICU, if you know any public health people who are trying to make these projections, it would be good to partner with them and to share that data so they can make better models that will predict more accurately for the local context. That's what I meant.
Thank you, Dr. Emma. I think this one's also for you. Considering the vast epidemiological difference between Uganda and the US, age being a key factor in determining the prevalence of the comorbidities associated with severity of COVID-19, what characteristics among the young people that have been seen in the US under or equal to 40 years are seen in the ICUs that Uganda may need to look out for as we go ahead?
Yeah, that's a very useful question right there. I would say that obesity is one of them, pre-existing lung disease, especially asthma. So asthmatics are at pretty high risk, especially if they are poorly controlled asthmatics. That is associated with higher mortality. The other problem, especially with the younger US population, is there actually is a pretty high prevalence of smoking, not your regular cigarettes, but a lot of e-cigarettes, what is called vaping. That's pretty popular right now. And vaping was marketed as a healthier alternative to smoking cigarettes. But now we are learning that vaping actually does pretty significant damage to the lungs. Knowing the Ugandan population, it's highly unlikely that a lot of young people will be engaging in vaping. And I also know that we probably would not have an obese young population. My other worry with youth is the ability to mount a very significant inflammatory response to a relatively small stimulus. So seeing an inflammatory cascade that will basically lead to organ damage. That said, I still believe that for our Ugandan population, we should still be looking out for those who are above 65, those who are hypertensive, diabetic with pre-existing kidney failure and cardiac disease. I still believe those will be the highest risk. I feel for Uganda, young people might still be pretty protected from dying from COVID.
I suppose we should add males as well.
Yeah, well, I mean,
because even the Kenyans.
yes.
Thank you.
Basically, being a man in COVID is not good. You rather be a lady. So, ladies, God has favored you with this one. Absolutely.
Amen. Okay, and I will just comment. I saw some hands up from the attendees. Dr. Richard Bugembe, you had your hand up. Would you like to unmute your microphone and ask your question or make your comment? Or there's another hand up if Dr. Bugembe is not yet ready. Just a minute. Atanasio, there's someone called Atanasio. Please unmute your microphone and ask your question. Please go on and speak, Atanasio. Okay, well, the two, yes?
No.
Oh, okay. I will read.
Maybe I can ask my questions as Atanasio.
Some more questions. Okay, all right. Yes, Fred, okay. Go ahead.
Thank you, Dr. Ayebale. COVID continues to confuse some people with simple minds like myself. Disparity between disease severity that we are seeing in Kenya. And I think I would say that in general, I don't think we are really missing cases. I think if we had people dying, catching them as COVID, we would know because people are really sharing the information. So for now, I see the major is a lot of money, which Uganda doesn't have, but I think most of the other demographics and other things are really still puzzles me why we are seeing more severe cases in Kenya. But, my questions allude to symptoms of patients with in Mbale, we have some interesting phenomena where we see young males presenting with severe hypertension. Don't know if it's coming as a symptom or rather hypertension, but these are guys in their early 20s. coming with hypertension. And that elsewhere, and if we should just pass it as pre-existing hypertension or as a new case. The other thing we're seeing is guys have headache that goes, I think, like 1 or 2 cases in Bale where someone has we haven't done a city, but yeah. So I would also like to see, especially Emma and Dr. Peter as well. What has been your experience with a high flow on nasal cannula oxygen? Thank you very much.
Sorry, Fred, you kept breaking up. I think I'll make a very quick comment and then I'll hand over to Dr. Kariuki to speak about high flow. Now, only because he's had more experience than I have. But what you're describing about these young men presenting with severe hypertension and headaches, unfortunately, as you said, we didn't do CTs, we didn't investigate these people. This could have been pre-existing hypertension. But even more worrying has been a lot of the mortality in young people has been from thrombotic events, particularly strokes and microvascular thrombi. So you wonder if hypertension was a manifestation of ongoing kidney disease that was missed. And if headaches was probably some sort of TIA that was missed. All that said and done, this just might be a different demographic for COVID patients in our setting. And it would be nice to document these cases and to share them with the world so that people in similar settings who are getting patients with similar presentation could confirm. Very quickly, high flow here, at least for the University of Washington, the protocol is patients who are not severely hypoxemic, who can maintain saturations above 80%. Actually, we dropped our cutoff points to 80%. If you're saturating above 80% and you do not look like you're air hungry, you are put on high flow nasal and you prone early. Sorry, in case you missed that, I'll just repeat that. Here at the University of Washington, patients who have saturations above 80% do not look air hungry, they are young, they do not have severe comorbidity, they are put on high flow and they prone and they self-prone. If there are any signs of deterioration, they are quickly mechanically ventilated. But I will hand over to Dr. Kariuki for his expert opinion.
Actually, our practice is not so different from what the manual is saying. Basically, people can maintain, for us, our cutoff is a bit higher. We should aim for 90% of saturations on high flow oxygen. So if you put a mask on you and find that your saturation above 90, you don't have those severe symptoms of respiratory distress, you just leave it at that. Unfortunately, in our country, we don't have the high flow cannula, so the best we can give is the non-liter mask. We go for the maximum flow of 50 liters per minute.
Thank you very much. I'll read a few more questions. There's one question, considering the younger population that you have encountered, especially those that have shown up as class 2 obese or higher with critical disease, what's your experience in terms of maneuvers aimed at improving oxygenation? I suppose this is likely for Dr. Kariuki. Also for Dr. Kariuki, there's a question on vitamin C. Could you elaborate more on its impact in the management of these patients? Thank you.
Okay, one thing I didn't mention about the obesity. This is from our observation that patients who are obese usually tend not to do so well, especially because even, for example, when it comes to proning, it's usually very difficult to even the self-putting so we usually have. So they end up getting intubated early, and then again when you intubate them, again ventilation also becomes a challenge because usually they require high pressures, acute pressures, and usually I would say that it's a bad prognostic feature for you to be obese and having severe COVID-19. And the other question about the vitamin C. Vitamin C, you know that it has an effect on the immune system. So these are some of the things we have been discussing from our colleagues, amongst our colleagues, and we find that patients who have been put on vitamin C usually eat better than those who are not put on vitamin C. So that's, I would say, an observation after giving the drug and then noticing that there's a improvement in the clinical status. I don't know that answered the question.
Mary, I believe we have finished answering those questions.
Sorry. Yes, you have. There's another question from the Q&A. For Dr. Kariuki, you've only admitted about 3% of the COVID hospital, and someone are being admitted. And I suppose between Dr. Ayebare and Dr. Kariuki, any idea of incidence of difficult airway anticipated or incidental, and associated outcomes of the emergent airway management among these patients? And the other question is there any point within an ICU setup with minimal isolation space that you'd say is safe not to don PPEs and no risk of transmission? Thank you.
Okay. Maybe to answer the first question, we have admitted 3% the COVID patients. This is 3% of the patients who have been admitted in a hospital. So we have several hospitals which have been admitting these COVID-19 patients, but of course the ones who have come to our hospital, I think we have lost around 3 patients before they reach the ICU. Now we have out of the 24 patients who have been mechanically ventilated, we have been able to successfully 4 patients. The rest 20 have succumbed. So the mortality rate is usually very high when the patient gets ventilated. So among the other ones, around that deaths. These are deaths which have occurred in other hospitals in the country, or maybe patients have succumbed from, they come to the hospital very sick, and then a COVID test is done, and then it's only identified that died COVID, but they were already not in the hospital. About the difficult care, what we decided in our ICU, we the anaesthesiologists are the ones who usually do the investigations for these patients. And I've not had, myself, I've not had a difficult, my colleagues have also not had a difficult airway. I wouldn't say, I wouldn't support of any incidents of this difficult airway, unless maybe if I can anticipate that maybe I could have asked my from other hospitals. Unfortunately, at the moment, I don't have that. So about the question of there is any point in ICU setup in the solution space that we say it's safe not to do with no risk of transmission. This is a question. It depends on the design of the ICU. Our design of the ICU, we have the ICU space, which is usually in quite good. Then our ICU usually has a negative pressure, the whole of the unit. And then now we have you usually try to keep the doors that are going to the isolation where patients are. Usually refer to it as the contaminated area. Usually like to keep them closed all the time. So now when you're outside those contaminated areas, you consider these other areas as clean areas. So when you are in those clean areas, you only do now when you are entering the area, that is the isolation unit. Thank you.
Thank you, Dr. Kariuki. Emma, do you have any comments?
Yeah, just very quickly.
With regards to the... Okay.
Yes, difficult intubation, I don't have figures at hand, but there has been reported cases of difficult intubation, so much so that now the protocol is all COVID intubations are done by anesthesia. All COVID intubations, first pass has to be with a glide scope. Of course, I appreciate this is the US, and I appreciate that this might not be applicable to all settings, but the idea is maximize first pass success. So use a glide scope, and you know, from intubating some of these patients while donning that full PPE with a PAPA mask, with a PAPA hood, and maintaining strict infection control procedures, it's a very stressful situation, and it's a very strange way to intubate. So, and of course here there's a, you know, obesity. There's a pretty obese population. So I still think that for Uganda, that will not be so much of a problem. I don't anticipate difficult intubations per se for our Ugandan population. That said, whatever modality we choose to use, I think it's important to maximize first pass success, because aerosolization happens the most during intubation. So you want to make sure that you do that quickly, and then you seal off that airway as fast as you can. I think for ICUs that don't have negative pressure, you have to assume that as long as there's a COVID positive patient in that ICU, and there's any times when you're aerosolizing, you can best assume that that ICU is infected. If you have negative pressure rooms or some sort of strict isolation, keep those doors closed as much as possible. Open them very quickly and close them very quickly. I think the truth is we'll just have to maintain as best infection control practice as we can within the limits that we have, and hope that we don't contaminate the ICU.
Thank you very much for that. And the last few questions here. Dr. Kariuki, the patient in whom no respiratory maneuvers would work, what was the imaging like, if any? And was lung compliance assessed? And the second one is for the acute kidney injury patients, was this happening only in the context of MODS, or and what was the presumed leading cause of AKI in your cohort of patients? Thank you.
Okay, about the imaging of this patient who had very severe ARDS. What I would say that I've been doing so much imaging because when we started, there's a unit admitting these patients. The infection prevention protocols for other areas where the COVID negative patients are also accessing were not in place. So we didn't have much imaging for those patients. We only regard imaging which was usually done when the patient came to the hospital as a suspect. But from the few things, usually the usual widespread opacification in young fields. And then for the compliance, the only thing you notice that usually the compliance usually goes through as the disease progresses, and then you are not able to oxygenate. Usually the lungs become somehow stiff, but we have not done a test to test the compliance. What we have relied on is the driving pressure. we find that as the progresses, they usually require pressures and when you are admitted. And so they also require high PIP, trying to raise the oxygen tension. Then for the AI patients, this was not happening in the context of morbidities, because there are patients who just had acute kidney injury and they never went to either the septic shock or the arrhythmias. So I would say that this is the acute kidney injury occurred as part of the pathologic process due to the virus itself, in the effects of the kidneys.
Thank you very much. I think I will hand over to Dr. Atumanya.
Thank you, Mary. For those who still have any more questions, we can put our hands up and we shall respond to them. I see, just 1 second. No, they've put down their hands. Yeah, I think if we don't have any more questions, that marks the end of our interaction. It's been great and informative. So unless there are any more questions, thank you, Dr. Peter Kairuku and Dr. Emmanuel Ayebali. We shall.
Thank you very much.
Yeah, the Zoom will be available. Dr. Fred will upload it for those who missed some parts or those who wanted to listen to the entire session. Yeah. If there's nothing more, I would like to say have a good evening to everyone. Thank you for participating.
Thanks, everyone. Thank you to the
So much,
panelists.
guys.
Thank you.
Thank you.
Thank you, Peter.
Thank you, doctors.
Thank you. Bye.
Have a
Bye.
good evening.